Uh, your presence is more than helpful in answering a lot of these questions that we would not be able to answer without you. And um, I think it's really great. I mean, it's important for people to ask questions. It's important for people to understand that there are research options out there and that technologies are being developed at an incredibly rapid pace. We're advancing out of a straight hormonal therapy. There are medications now where, as you talked about, immune checkpoint inhibitors. And we maybe our Dendrion product, which is Provenge, will come back again to another strength because it will be very easy to monitor its progress looking at PSMA PET scans. And maybe it'll have another role in the management of diffuse recurrent disease in people who have been primarily treated and have unfortunately not done well with local curative therapy. So looking at all of these additional treatment options, I think that it's going to be great looking to the future over the next 5 to 10 years.
Yeah, certainly as a new medication comes along, the things you think about studying is things like biomarkers. So can we identify people who are going to be those exceptional responders and give it to them earlier? We're getting some great information from PSMA PET from the imaging, where if their total SUV or the uptake, the amount of PSMA that's sticking to the cancer is high, or if it's above 10, this number of 10, that those people are going to be better responders. It doesn't mean that the other people don't respond, but we're starting to tease out who responds better. We're starting to, as you said, and we've talked about tailor therapy and add in external beam radiation or ablative therapies for oligometastatic disease. We're truly learning something every day because these new systemic therapies, can you give them in combination with things like androgen deprivation therapy? We had a trial that's accrued in men with newly diagnosed disease that spread to the bones, and it's moved all the way. Pluvicto is moved up in that trial alongside standard androgen deprivation therapy or hormone treatment. Can you give it instead? That's what everybody's asking. The patients want to know if it can be given instead. We're working to get there. We're trying to study hard.
Well, I think you've actually dovetailed into one of the topics that I look forward to covering, which is the genetics of prostate cancer, because there's really two types that we need to look at. One is the actual tumor genetics, and the other is the actual somatic or body genetics of the individual who's harboring the prostate cancer, so that we can approach both of those looking at the idealized treatment option for that patient.